Okay, I'm going to get started now. So welcome everyone, and thank you for joining the webinar this afternoon. It's great to have so many of you here and so many still joining us, which is fantastic. Hopefully those joining won't miss too much. So we ran a similar session to this last year to support you with your data cleaning and validation work, and that session we had a more in-depth focus on cleaning your NNAP data and how to do that. And this year we're going to do a similar general overview, and then have a bit more of a focus on the preterm brain injury data, so we can really get into the detail of why that's important and what we should be doing with that data. So just a reminder that we'll be recording the session, so it's available to watch back later, and that will be available on our web pages, and we'll send that out in an update when it's available. We've muted all of your mics for now while the speakers present, but we will give you control of those back during the Q&A session. And then if you want to ask a question, you'll be able to raise your hand and unmute your mic when I come to you. But please do keep your mic muted when you're not speaking during that session. We've also disabled cameras just to help with the bandwidth, to make sure everything runs as smoothly as possible. And I can see myself freezing, so I might turn my own camera off in a minute. And you can also use the Q&A function to write any questions that you have that come to you as the speakers present, and I will come to those during the Q&A session and raise those with the speakers. So just to, so I think that's all in terms of housekeeping. Just to recap aims for today. So we hope by the end of the session you'll understand why we're asking you to really look in detail at your data and to clean it, and to give us assurance and validation to some of the NNAP data around outcomes and how you can go about doing that. And that Sam Oddy will cover that. We'll also hear from Professor Chris Gale, who will talk about the importance of high quality benchmark preterm brain injury data and how he approaches that locally. So once Sam and Chris are presented, we'll dedicate the rest of the sessions to Q&A. Hopefully there'll be plenty of time for that. But anything you don't get a chance to ask today, please do ping us an email or get in touch. We're always happy to answer questions. So I'll now invite Sam to present to you. So I expect most of you will already know Sam. He's been the clinical lead on the NNAP for, I think, 11 years, if I've counted that right. And he's also neonatal clinical lead for the National Maternity and Perinatal Audit, which is hosted by the RCOG, which is a fantastic link for us to have. And Sam is a consultant neonatologist in Bradford. So over to you, Sam.
Thank you very much, Rachel, and thank you all for being here. Fantastic turnout, and no doubt there'll be more pinging of the Space Invaders as more people come in, which is great. Thank you very much indeed for making time in your busy schedules. So that I'm going to give a very pedestrian talk. All the real interest is going to come from Chris. Is going to tell us exciting, novel, sciencey things. But what I'm hoping to do is to give you an idea about how you can most functionally make sure your data is as good as it can be. I think the high level of buy-in that we've got to this webinar kind of shows, well, it's illustrative of how highly valued the data function that we have in the UK is, and everyone's got a commitment to getting that as good as it can be. So what I'm going to try to do today is explain how our data validation processes work, and think specifically about the different measures in NNAP, in National National Audit Programme, and try to think specifically how units might approach those measures and the data underlying them differently. Hopefully by the end of it you'll have an understanding of when, if you change something in Badger now, when that will show up in the reporting that we do, and a little bit about the future of reporting, but that's not going to be the main thing I'm going to cover. in essence, we think we do have a data validation process, and probably everybody who's on this call is familiar with the so-called quarterly reporting that we've been running out of NNAP for some years now. And that so-called, we call those Q reports, those quarterly reports were initially a completeness report, but they're increasingly a data quality report. And they look like what's illustrated on the slide here. And the idea is that they show you how your data looks to us. The reports do provide some comparisons of the current state of your data to national average. That's to some extent been superseded by the dashboards that I will show right at the end. But we hope that it might have some quality improvement utility. Importantly, these quarterly reports describe the proportion of missing data, the proportion of cases where, in the case of a process measure, the standard isn't met, and it tells you how many cases are involved. As I say, though, so I'll come back to our Q4 reporting and the validation survey later on. So here is an example of a so-called quarterly report. This is obviously for Bradford, and I want to draw your attention. So I've picked out temperature in this case. So for each measure within the audit, there's a report, and this is Bradford's one. And importantly, we talk about the audit measure, which sometimes changes between years, although we try to obviously minimise the amount of changes. You can see that there's been a change for the 2023 data year. And we find that the specifics of the measures are very important to people as they look carefully at their data. So we always want to signpost people to the so-called measures guide, which you can just Google NNAP measures guide, and the one for the relevant year comes up. You can choose the right one for the right year. So we find that referring people to the measures guide very often helps them to resolve questions that they have. So alongside receiving a report that looks like this on the front and that has pages that look like that, alongside those Q reports, we currently issue a spreadsheet, which in the case of anti-natal steroids in this example, but you can see down the bottom there's a whole bunch of different tabs for different questions. But here I'm showing the anti-natal steroid tab of our Q report. And I've kind of condensed the columns so to protect the identity of the innocent. But you can see that a bunch of patients have received anti-natal steroids, course is complete, and there are some that have been given early, somewhere it's blank, somewhere the course is incomplete, somewhere steroids are known not to be given. So this describes kind of how the data are at the particular point in the year when this report was produced. And what I'm going to go on to do is to show you how we think you can reasonably address each measure. So as everybody knows, there's a whole bunch of measures in the National Neonatal Audit Programme. And these are all shown on the slide. Or nearly all, I think. So we include almost all, but certainly not the less than 27 or 28 weeks for multiples cared for in an on-site center with NICU. That what we call the 27 measure isn't in the Q reports, but most of the NNAP measures are in the Q reports. I'm going to go through these measure by measure to give you a feel for what we think you can do. So starting at the bottom, with some of the parental partnership measures. And inevitably the function of cleaning data has evolved over time. So you might think that I'm not describing a high enough standard for data cleaning, in which case I hope you'll put comments in the chat. But for parental consultation in particular, in Bradford, I review all the missing and the where the consultation appears to have occurred early or late. because my experience has shown that sometimes I need to go back to the primary record in order to get the correct data into Badger. Depressingly often where it's missing, it's not the case, it's genuinely missing, but I look at all the notes for, and in my case paper notes, in my trust paper notes, for all the missings late and where the consultation occurs early. For parents on ward rounds, I'm not currently cleaning that data in Badger. Breast milk feeding, I review any missing data, of which there's usually none. But for care processes, 2-year follow-up, my colleague is actually, Dr. Locke is now doing this, but we where Badger, where the NNAP data tells us that 2-year follow-up has been done, then we don't follow those cases up. But if the quarterly report suggests that it hasn't, that 2-year follow-up hasn't been done, or it's been done outside the time frame, then we go back to the primary data, and that involves going typically going back to Cerner, our EPR, which we do our outpatient recording on, and seeing whether a child's been seen in the relevant time frame. I'm going to talk about ROP separately. The nurse staffing data, where there's any missing data, I take that back to nursing staff and we get the correct number of nurses in. So typically that's days where it's blank. There's usually very few of those, and I would review any missing data for non-invasive breathing support, but there hasn't been any. Whoops, that was exciting. That's not what I'd intended to do. So there we go. Optimal perinatal care. This is probably an important part of the data cleaning activity that we do in the trust. And I know that, I suspect that in England at least this is very similar, because we're all being obliged to look very carefully at our optimal or perinatal optimization data from that NeoSIP. So where for antenatal steroids, we review all the cases where antenatal steroids are apparently not given optimally, if there's any missing data or if there's any unknown data, and we go back to the woman's records, woman's prescription chart if necessary, to address that. And we do the same for magnesium sulfate, where I'm glad to say there's usually not much missing data. For deferred cord clamping, we'll review if that doesn't take place. If someone says it has taken place in the correct time frame, then we don't go and check that, but we do review the where it doesn't occur and the missing and the unknowns. Temperature for admission, many of our non-adherent cases are apparently late temperatures, and that's usually around the admission time being incorrectly recorded in Badger. And so we typically have to go back and look at a significant number of babies of less than 34 weeks to see whether admission temperature was genuinely done late, which is very unusual after an hour. And we don't normally end up changing the temperature, but we do sometimes changing the time. And breast milk feeding the first 2 days, we will address any missing data, but there's very little of that. So clinical outcomes, so bloodstream infection, I'm going to talk about that separately. Bronchopulmonary dysplasia, we in Bradford at least we experienced very little missing data. In fact, there's very little nationally. But if there was a case where the BPD status couldn't be described for an individual baby, either for a baby where the outcome occurred in my trust or where the case was attributable to so-called BPD responsible tab, then I would go and address that. NEC I'm going to talk about separately. Preterm brain injury, again, I'm going to talk about what we do separately. And mortality, much less missing data nationally than there used to be, but if there were any missing data for mortality, then or any undescribed outcome in my spreadsheet, then I would certainly be making sure that that was described in Badger. So for retinopathy of prematurity screening, where there's anybody who's not met the standard or any missing data, we go back to the primary medical records, which, as I've said, are typically written for inpatients. We also find the so-called ROP book, our very 1990s way of managing ROP booking. We go back and use that as a tool. And there's a sign-off process in that, and we've found that very helpful. I have somebody who specifically who handles that. 2-year follow-up, I think I've already mentioned. We have this mixed architecture of medical record keeping, which makes it more exciting. But we and where we notice any changes, I tend to record those on the spreadsheet. So I showed you earlier this spreadsheet. and in fact, I've got an example coming up, but I record a column. So if I was making some changes for antithesis, I'd put an extra column in here. I try to keep a track of changes that I've made on account of those things. So bloodstream infection in my organization, I'm extremely lucky. One of my colleagues oversees that, gets a feed from microbiology, and makes sure every positive blood culture is entered into the Badger system. So for me, I simply ask him, "Are you confident you've done that for every positive blood culture?" And he sends me an email back, "Yes," and that's my assurance that's the case, and I can be confident in that. Preterm brain injury. Chris is going to talk about the significance of this in a bit, but I find that the recording of this is not as good, is not as accurate as I would like it to be, and I find it necessary to review every single case to some extent. So the way that I do that is I review, to start with, the discharge letter of the baby. And if it's a well-grown 31-weeker and somebody writes that the scans were normal, then I look at the headline diagnosis in the letter. I'll scan the summary section of the letter. And I would read the central nervous system section of the letter if someone had written one. But I find that quite often it's necessary to go to the primary radiology system to see what's been recorded actually by the radiologists. And so I find that that's it's somewhat laborious. It probably takes me a couple of hours to do all the babies in Bradford. And in fact, my fine colleague, Dr. Locke, has been helping with that. And then when I make a change, I add a column to the spreadsheet, which I've saved locally. And I keep track of what we're doing. Now, we've not completed this for the Q3 report, so we're going to have a busy time after the Q4 report comes out relatively shortly. But that's how we address the IVH and CPVL data. So we'll do something similar for necrotizing enterocolitis. Because not only are we interested in data completeness, but we're also interested in data quality. So I look at every baby of less than 32 weeks' primary discharge record, and I use the spreadsheet to find out the cases that are attributed to my centre for outcome and where the outcome might have occurred. And I review the letter, I read the headline diagnosis, I always read the summary text. And I'll read any relevant subsections. Where there's a question of there might have been necrotizing enterocolitis, I will certainly look at the radiology. And I think some of you will have joined us last year when we had a comparable webinar. I find most years it's necessary to correspond with at least one colleague in a neighbouring neonatal unit. Last year, Lawrence Miles sent me a photograph of the bowel of a baby who had a spontaneous intestinal perforation, because he wanted to be super clear that I would understand that the baby had an SIP and not NEC. And it's great to be clear about that, and we both then made sure we were using badge to describe the same outcome, and that is, I find, necessary with NEC. So it's usually necessary for me to correspond, about 1 or 2 babies in general. But I find it necessary to review every single case in order for me to be confident that we've accurately described the NEC outcome. So I wanted to say something quickly about what we're doing and when we're doing it. So the week starting the 29th of January, sometime during that week, we'll be sending you a Q4 report. And that'll come out via SharePoint folder, so you get an email allowing you to click into SharePoint. In February and March, we'll be sending out the data validation survey. Now, that is a survey which comes to the NNAP clinical leads, and it asks the question, are you confident in your infection data? Can you assure your NEC data? Can you assure your brain injury data? And we will keep sending you that until you tell us a definitive answer. And we're extremely grateful for people's engagement in this. We find it fantastic. There is a final deadline for the 2023 report data updates. So the data that gets changed before the 31st of March, that will count in the report. Anything done after that won't feature in the report. And we anticipate that the report will come out sometime in October. The final date is not actually within our control, but it'll be sometime, we think, in October. During the 2024 data year, which of course we've already started, this process of spreadsheets to be accessed via SharePoint and reports that I've talked about will be evolving a little bit, and it'll be you'll access it in a different way. But although the sort of the look of it will be different, the underlying purpose will be the same. And so we'll notify you about that via email in the important updates email that we'll send you. So I want to tell you just very quickly about outlier measures. We are going to be identifying outliers for a whole bunch of things, as we always have done. You'll see temperature, BPD, treatment effect, NEC, treatment effect, 2-year follow-up. We are going to be describing for the first time outliers on the basis of how much missing data there is for severe IVH, IVH3 or IVH4. And so you'll see that there'll be a significant amount of outlier identification going on. There's a new outlier policy come out from HQIP. We're pretty sure that all of our stuff is consistent with that, but we will need to revise our outlier policy to take into account the newly published guidance, which came out last week. There's no really important changes to the metrics for 2024 compared to 2023. A minor change around the denominator for temperature, but don't need to talk about that in too much detail. We do update the measures guide periodically, and you'll find the most recent version on the website, as I mentioned earlier. I hope that the dashboard, the NNAP data dashboard, is familiar to those of you who are on the webinar and useful to you. This is the front page, the more exciting page. The pages look, and if in this example, here we have on the horizontal axis from 2016 through to 2023, and this is the rate of babies under 34 weeks. You've got all relevant perinatal optimization interventions, and you can see that only about 1 in 7 babies get that. And hopefully the blue line, the blue diamonds are one center, in this case a region, and it shows change compared to the national, which is the black dashed line. Importantly, the red is missing data, and so missing data's got very low, presumably as a result of that NeoSIP. A version of this that is specific to your unit and shows you on a measure by measure basis is coming out shortly. We're just entering the testing phase of that. So with that, I'm going to get off and get Chris on. So thank you very much indeed, Chris, for agreeing to talk to us about preterm, about brain injury in general, I should say. Many of you will be familiar with Professor Chris Gale. How could you not be such a personable and charming young man as he is? So Professor of Neonatology at Imperial. So thank you very much, Chris.
Thank you, Sam. Yeah, so I've been asked to come and talk a little bit about brain injury in the context of the audit and audit data. And I think Sam's done a really fantastic run through of a very comprehensive approach to obviously validating your data at your site. I'm probably not going to add a great deal to that. I'll talk a little bit about what we do locally, but I'm mainly here to, I guess, make the case for the importance of this measure in particular, which probably doesn't really need making, but I'm going to have a go anyway. I'm sure everyone on this call, as a self-selected bunch, probably appreciates the importance of brain injury in babies. Let's just see if I can get it to move. Great. Okay. So I've been fortunate enough to be involved in the development of this measure, which is several years old now. Introduced in 2021. Just to remind you, this is babies less than 32 gestational weeks of birth, and the attribution of cases is to the unit and also as a consequence of that, the network of birth, depending on which analysis you're looking at. And this is a composite of, of severe brain injuries, really. So it's IVH, intraventricular hemorrhage grade 3 or 4 on the Papille grading system, post-hemorrhagic ventricular dilatation, and cystic paraventricular leukomalacia. So the things we really worry about. And as Sam mentioned, this is, for the purposes of NNAP, it's derived from the cranial ultrasound scan imaging section on the Badger system. And you can see how it is recorded here. There's obviously really nice detail in the various NNAP documents that explain this in great detail. So these discharge questions, which will be auto-generated based upon the number of cranial ultrasound scans that have had data entered into them. and then you can go back to the individual scans and record whether a baby has had an IVH, cystic paraventricular leukomalacia, or post-hemorrhagic ventricular dilatation. And it's from those that this data, for purposes of NNAP, is extracted. And as a result of that, we have some idea as to whether there is a component of missingness for this. It's much easier to determine missingness for this on the understanding that these babies less than 32 weeks should have had a scan recorded in the system at some point after birth while they're on a neonatal unit. So that enables us to look and basically determine cases where there is no scan recorded as a reason why they don't have a brain injury recorded. I think it's really important to notice, I'm going to talk about it in a minute, but preterm brain injury is being looked at nationally through a couple of different processes, one of which is NNAP. Another one is reporting for the Department for Health and Social Care brain injuries, monitoring as part of the National Maternity Ambition. That uses a slightly different subset of data, although these data that feed into the ultrasound scan fields will inform that as well. So if you enter it into the ultrasound scan fields, you will deal with both NNAP reporting as well as reporting for the Department for Health and Social Care National Maternity Ambition. So that's a bit of the kind of nitty gritty, the detail down in the weeds of how it's extracted from the various systems. I think a broader question, and one that I'm probably happier talking about, is why should we benchmark perinatal brain injury? Why is this important? And yeah, I probably don't need to labour on this, but I'm going to just highlight a few reasons here, and then I'm going to present some data from some work that's been done by a PhD student who I'm supervising called Philippa Rees, who's done some fantastic systematic reviews just to kind of highlight, I guess, the summarised data of the long-term neurodevelopmental consequences. So we know from quite a lot of work with families and ex-preterm adults that this is a really important aspect. It's been identified as a core outcome by hundreds of parents and ex-patients when asked about what outcomes really matter following neonatal care and preterm birth in particular, and it continues to come through in all research studies really that ask questions about outcomes. So neurodevelopmental impairment and brain injury that you can detect in the neonatal period is really critically important to babies and families, and I probably don't really need to say this here, as I'm sure everybody is well aware of this when they speak to families of preterm babies in particular. And the reason for that is due to the long-term neurodevelopmental consequences, which I'll talk a little bit more about in a minute. Ooh, just go back. It's also a key component of the National Maternity Ambition. This was several years ago now, where the government announced a new commitment to ensure England is one of the safest places in the world to have a baby. This has survived several changes in leadership and government. And as part of this ambition, the idea was that the number of brain injuries occurring during or soon after birth, which was not further defined at the time, will be targeted as part of this new commitment to bring this down, to halve it over time, along with halving the rate of preterm birth, neonatal mortality, maternal mortality, and stillbirth. Subsequent to this, there was then a little bit of work that was done to determine what exactly brain injuries occurring during or soon after birth meant. And there was a broad consensus that this should include both term brain injury, like HIE and stroke and meningitis, but also preterm brain injury, which had usually been left out of these kind of measures. And as a result of that, intraventricular hemorrhage grade 3L4 or cystic paraventricular leukomalacia is included in this National Maternity Ambition target. So not only does this matter for NNAP, but it also matters for measures that are used by the Department for Health and Social Care and also fed back to your trust through that process as well. And just to reiterate, the data from this is extracted from the National Neonatal Research Database, which of course is slightly different from the data used for NNAP, but it's derived from the same fields within Badger. So the ultrasound scan fields will populate both the data that's used to inform the National Maternity Ambition, but also the data fields used to inform NNAP. So please do fill it in the ultrasound scan fields where possible. So why does it matter so much? Why are we so interested, both in terms of NNAP, but also in terms of the National Maternity Ambition and in terms of our own care and in terms of the parents and families that we look after? And that, of course, is because of the long-term outcomes. I just mentioned before Philippa Rees, who is an aspiring neonatologist who's currently undertaking a PhD And she's done some really fantastic work bringing together the data from the last 20 years of studies, really, that have looked at neurodevelopmental impairment following severe brain injury, in particular the conditions that lead to brain injury identified as part of the National Maternity Ambition. I'm just going to very quickly zip through some of her recent systematic review and meta-analysis results. She's also working at the moment on some linkage between national neonatal data and national pupil database data, so educational outcomes, to try and provide even more detailed and larger scale population level data on the impact. So hopefully we'll have that information in the next few years. But you can see here that in these studies, and Pippa identified studies that had found babies with different forms of brain injury, and I'm focusing on grade 3 to 4 intraventricular hemorrhage here, and that were compared to matched preterm comparators who didn't have intraventricular hemorrhage. So it is actually matched for the prematurity, which of course is a key element when looking at the impact. And this top line here is neurodevelopmental impairment up to age 3, generally at kind of around 2 years, using Bailey or a similar type of neurodevelopmental assessment. And you can see here that the odds, if you have a grade 3 to 4 intraventricular hemorrhage, of you having neurodevelopmental impairment detected at that point, is about 3.5 times higher if you have a intraventricular hemorrhage compared to not having one but being born preterm. Motor impairment also clearly really important, in particular to families, and cerebral palsy, being a highly feared complication. As I'm sure many of you know, this is even higher. There's even a stronger association and a higher odds of being affected with cerebral palsy, which can normally be detected quite well up to 2 to 3 years, as opposed to cognitive measures, which are more challenging. And you can see here that there's a 5-fold increase in odds in developing cerebral palsy detected at 3 years if you're affected with a grade 3 to 4 intraventricular hemorrhage. Pippa's also managed to extract some studies that looked at school age outcomes, so neurodevelopmental impairment at mean 8 years, again in preterm babies with grade 3 to 4 IVH compared to preterm babies that don't have that. So again, accounting for gestation at birth. And you can see that there's a pretty similar factor here. So an over a 3-fold ratio which persists right up until school age. A smaller number of studies, just I guess demonstrating the challenges in long-term follow-up that we're all well aware of. And a similar pattern is seen for cerebral palsy, if not actually higher odds seen in these studies that followed children up to school age. So really an important motor impact for grade 3 to 4 IVH, which persists right through childhood and obviously, presumably through into adult life, although that data, of course, is even more sparse. I think it's also important to note that low-grade IVH is important. There's quite a lot of work going on at the moment looking into this, and hopefully the quality of data that's coming through and improved quality driven by things like NNAP will mean we will have better quality data on grade 1 and 2 IVH. I know that isn't reported through the NNAP outcomes measures. Again, this is just some work from Pippa suggesting that actually there is a reduction in IQ that's detectable following grade 1 to 2 IVH compared to unaffected, again, gestation matched comparators, and also an increase in cerebral palsy at school age, even with grade 1 to 2 IVH compared to unaffected, similarly preterm comparators. And clearly there are some challenges around the quality of data at national level in relation to grade 1 and 2 IVH, which is a little bit more subjective, but hopefully we'll be able to see some further details going forward and be able to use the high quality national data to evaluate that. So what does it look like in a national picture? This is data over the last 10 years, really, at a national level, looking at the number of brain injuries. So this is not just IVH grade 3 and 4. This includes HIE, meningitis, encephalitis, stroke, as well as IVH, cystic periventricular leukomalacia, and the very tiny numbers of babies recorded as having connectorus. And it's largely driven by IVH and HIE, as you might expect. And you can see there is possibly a little bit of a pattern of a slight reduction across all gestational ages over the last few years, possibly. when we look at preterm infants in particular, where it's very much driven by intraventricular hemorrhage as the leading cause in these preterm babies, actually you can see there's really no evidence of a decline at all. So we may be seeing a reduction in term brain injury, but certainly no reduction in preterm brain injury. So really an area to focus on here, and that's why the increased attention to this through the NNAP process, I think, is very welcome. What about for the NNAP data? You've seen the report, you've seen this, about 7.5% of babies are recorded as having a grade 3 to 4 IVH in the NNAP population of interest. And unfortunately, the missing data is noted to be high, so higher actually than the number or the proportion of babies with a recorded diagnosis of grade 3 to 4 IVH. You've seen these caterpillar plots, you know how to interpret them, so I'm not going to dwell on that. I was just going to mention here the fact that missing data by network, which is what this is the column from, you can see overall is high, 13.9% as you can see, and there is some quite significant variation between different networks, which I'm sure you are all well aware of within your networks. That I guess just highlights the ways that maybe we can improve this and learn from other units, other networks. Sam's also mentioned this, the NNAP data dashboard. This is the complications of prematurity page, which includes IVH and the other brain injury measures, as you might expect. You can, of course, pick your network and have a look here. Some networks have quite high levels of missing data, so the block of red there is the missing data. This is for one network, some improvement over time. And I think it's probably just worth noting that maybe there are other networks to learn from, and clearly that's, I guess, part of the point of this seminar today, is to try and learn, and hopefully people will have suggestions, and in the discussion we'll be able to bring some of those out. This is just data from Scotland, just to show really that even though they've joined relatively recently, without as much time to prepare their data validation processes, they have remarkably low percentage of missing data for these complication outcomes, which I think is, again, an example, I think, of good practice that's hopefully we can learn from. So what do we do? So in terms of ultrasound scans, brain injury data, we have quite a robust process of cranial ultrasound scans being reviewed both by a consultant within a day or so of them being done, and then a great many of these are reviewed at our weekly kind of multidisciplinary grand round. It's common. We also are very fortunate to have experienced external review of our imaging from a dedicated kind of neonatal perinatal neuroradiologist, really, in cases of uncertainty, which certainly helps. We would do that prior to it being entered into the system. And we would review cases of severe IVH or cystic paraventricular leukomalacia in our grand round, so that we can discuss those there. And then prior to babies being discharged, we would have their discharge summaries, so their badger summaries would be reviewed by a consultant every week before discharge. So that just is the SCABU consultant in the case of our trust. We try to use this to inform practice locally. And understand the adverse outcomes we've had, and I think it is important, and I think it probably is valuable both in terms of making sure our data is as high quality as it can be, and I think we probably, well, I know we could certainly improve in that, and listening to the very robust process that Sam outlines, I think that's, again, yeah, a salutary lesson in just the kind of multiple levels of validation which are used in sites that have no doubt excellent quality data. And I think there is also importance in understanding how clinical practice influences adverse outcomes. I think we're getting better and better at doing this for cases of mortality through the perinatal mortality review tool process. Probably it's not quite as robust in terms of looking at morbidity. And certainly this is one way that we are able to do that for this type of morbidity in particular. Great, I don't think I've got anything else to add here, so I'm going to stop sharing now, which I think I've done, and I'm going to hand over now at this point to Sam and Rachel.
Thank you so much, Chris. That was really informative talk. Thank you. Yeah, so now we've got time for some questions for Sam and for Chris, for the NNAP in general. So I think your mics should now be enabled. So if you want to raise your hand, you can do, and you can. And if I invite you to talk, you can obviously need to unmute your mic. We've got a few questions on the Q&A to get us started, mostly for you, Sam, I think. So let's go to the beginning. So first question is about breast milk measurement. So question that in our trust we have breast milk measurement in the first 24 hours, not within the first 2 days. Is this something that will be changed to 2 days across the board?
Thanks very much, Vicky, for that. So it's great that your trust are targeting getting breast milk in within 24 hours of the baby being born. Well, we all agree that the earlier we give milk to nearly all babies of less than 34 weeks, the better. The reason that we have the question about day 1 or day 2 is because that's the only bit of Badger that people are completing at a national level with sufficient completeness. So certainly for 2024, we're going to stick to that measure. But we understand the importance of people entering data using the UNICEF Baby Friendly page, which is no longer just in the discharge tabs, just in case you were wondering. And that will allow us to answer questions about breast milk administration by time rather than just by calendar days. But thanks for asking the question.
Thanks, Sam. So next question, a couple of questions actually around 2-year follow-up data. So any tips, please, if families have moved out of the area and you can't get information from the new trust? And there's also a follow-up, another question that I'll try and ask at the same time to you. So when the 2-year follow-up is completed at another unit, our consultants have been told not to use the responsibility of another unit option. Is that correct? And if so, when should that option be used?
So let's deal with the second question first. So your consultants have understood correctly that the Badger system is, of course, not the same as NNAP, and somebody prevailed upon the Badger provider to put that ability to trade patients between organizations, which is understandable from a clinical basis. But we're concerned that if we make that part of the analysis, that there won't necessarily be an acceptance by the apparent recipient unit that follow-up is their responsibility. So there is ongoing negotiation with I've temporarily forgotten the acronym for the BAPM neonatal follow-up with BANFU, British Association of Neonatal Follow-up. But there's ongoing negotiation about that. But your consultants have understood correctly. So I agree that following up babies who've moved to another place is really challenging. And I recently lost contact with a very high-risk family about which I'm extremely disappointed. Who slightly had fallen out with another organization and then managed to fall out with us too. It is very challenging, and there's systematic evidence that children who are followed up with difficulty have a different and actually worse outcome than those who are followed up with ease. So I think clinicians all understand that it's our responsibility to do everything we can. If we know a family's moved, then we should be writing to a clinician in the nearest hospital to where they now live and saying, please, can you offer them an appointment because ongoing follow-up is necessary because they were born 29 weeks or whatever. If you know that they're somewhere else and you can't get engagement in the local centre, then that's very challenging. And my sympathies are with you. I think as clinical staff, we should do all we can to get children followed up and to record some information about that. And I refer you to the measures guide for exactly how much information is necessary, but a full Bailey's is not required in every case. That's all I'll say. Look at NICE guidance. Rachel.
Great, thanks. So the next question I will ask and then answer myself, if that's okay. So Matt Davies has asked if we could include the quarter next to the patient in our quarterly spreadsheets, and we definitely acknowledge that would be useful, and we've built that into the new data dashboard functionality that will eventually replace the current reports this year. I can't remember whether our analyst who's on holiday this week has planned to add that into our our SharePoint reports that are going out shortly, but I'll follow up with him. But it's definitely coming for the new system. And it's really easy to filter down into by quarter, by missing, and by which outcome a baby's had.
Can I pick up Janet's question?
Yeah.
So Janet Barrington asked if we says that they only scan babies are less than 29 weeks gestation. So if we actively record 0 scans as opposed to do not complete, does this count as missing? Janet, the answer to that question would be that if you don't scan a baby, then we will describe the proportion of babies of less than 32 weeks that do get a scan. We're not saying that that's wrong, but it will describe your performance on that metric compared to that of other units. So I think it's understandable to focus your scanning resources on the least mature population. The consensus was that all babies would get scanned, and that was what the expert group, of which Chris and I and others, which then went out to sort of a very extended set of peer review. But I hope that answers that question.
Great, thanks, Sam. So next question. With when you're looking at cleaning your data, how do you choose which categories you only look at missing data for versus looking at missing and the outcome, so no or yes?
Thanks, Rebecca. Great question. I love the word cleansing, incidentally. By experience, I think is the short answer to your question. So I find that for NEC, if somebody describes the baby patient as having NEC, then that sometimes is misrecorded, and that even happens in other organizations. He says, choosing his words quite carefully. So I think it's important to look very carefully when something is said to have happened. I've also come across cases where, on review of the case, I've thought the patient has had NEC, even though it's been recorded that they haven't had NEC. So that would be an example of a reason why I think looking at both the yeses and nos for NEC is a good idea. I think there's a practicality aspect. So if we take parental consultation, go to the other end of the spectrum of measures, I think it's not really practical for me to look at all sort of 600 admissions to the neonatal service and work out whether they had a consultation. So I'm trying to find a sort of subset that I can sensibly review with respect to that. But I think it's a fair challenge. Arguably, we should check everything. It does depend a little bit. We all use, nearly everybody, but not everybody, uses Badger. And people use their data and interact with their data entry systems differently. So I think it does depend. The question we ask, and so it depends on what sort of service you are and how you use your record system, the extent to which you need to cleanse the data. The question that we ask in the data validation survey is, can you assure are you confident in your NEC brain injury infection data? So we're trying to ask a very specific question. I've laid out what I do, and of course I've discussed this with colleagues in other places, but it is a thing that's developing as we move to EPR systems, as of course many of us are hoping to do. Then I think there'll be new challenges, but for me, some level of data review will still be necessary. Yes, of course, we certainly will share the slides, Sanjay.
Yeah. So question about caffeine and whether we've got an intention to add that into the NNAP measure set. And we have been talking about this recently, haven't we, Sam?
We have. Some of you will know that we are that we have been under strict injunctions, not too strong a word, to limit the number of measures that we had, and so there was not any clarity of purpose to expanding the number of measures to include caffeine. It's possible that there might still be an opportunity to do that. I think there are important questions around this, and particularly around the timing. So there's an enthusiasm for giving very early caffeine in some centres and in some body of a neonatal opinion, but by no means consensus that that's the safest and best option. And that's where we're at a little bit at the moment. if we are going to introduce a caffeine measure, exactly what would that caffeine measure be, and how would that make the world a better place? But thank you for asking, and yet it is something that is getting actively discussed.
Great. Thanks, Sam. So question from Hannah Wood. For those babies who are transferred, so this is about brain injury, for those babies who are transferred, particularly less than 27 weeks, who might be transferred to NICUs as ex-utero transfers, which unit is the preterm brain injury outcome attributed to, given this will be influenced by prenatal and postnatal factors?
Thanks. So attribution is obviously an ongoing it's always a live issue in NNAP world. We've actually reconsidered attribution for one of our measures recently. Naturally, we understand that it's possible that attribution might be that the clinical causation, if you like, causation is a bit strong, but association at least of brain injury with a place there might be some causal pathway around the time of birth, to the place of birth, or subsequent place of subsequent care. We've gone for the place of birth is the answer to the question. I think the current way that audits are being commissioned, encouraged to be provided, really, is going for kind of quite simplistic, but we hope that once the data quality is good, we'll be able to answer finer and finer questions about these things. And I think the long-term future of audits like this is that we might be able to do to vary the attribution sort of deeper into the level of the analysis. But that'll horrify Rachel. So at the moment, it's a place of birth.
Great, thanks. Another one about brain injury. So sorry, I can't see the name. Does anyone have any experience of agreeing a regional consistency in cranial ultrasound scan reporting to iron out differences in radiology approaches to reporting?
We don't have that experience in my own region. I'm not familiar. Perhaps somebody on the call might want to put that in the chat. That would be great.
Yeah, if anyone does, they can respond to that comment from Hannah. I think it's Hannah Chamberlain. That would be great. Yeah, I think this is a similar question as well from Claire. Our radiographer does not grade the IVH on head scans. Is it practice that the consultants decide this?
I think it's really interesting to hear the difference between the way it's done in Chris's hospital and mine, and I think it's likely to be individual. It's a clinical judgment, so radiographers typically, I think, wouldn't want to say this is grade 1 and this is grade 2. But it does, particularly in differentiating between, and that's why Chris and I and others went through this careful process of deciding exactly what counted as grade 1, 2, 3, and 4. And their words for those are expressed in Badger if you don't want to go to the measures guide. So you click on the I box in Badger and there's enough there to be able to make the differentiation. So I would think that consultant radiographers or potentially consultant neonatologists would need to make that differentiation. Thanks, Clive, for asking the question.
Yeah, no, I'd agree. I mean, we don't even, our radiologists don't report it, our radiographers don't report it. It's purely done by the clinical teams. So yeah, it's very much a decision made on the ward round and then reviewed in our kind of grand round if it looks abnormal. And I think that's quite a common approach, isn't it, across lots of sites?
Yeah, in my place, it's all radiologists. I gave up ultrasound in the brain when I started moving to the moving ventricles, but I don't really look at those much now either.
Great, thank you. So, question from Lawrence Mile. Thanks, Chris and Sam. On basis of a Saving Babies Lives spreadsheet we were asked to complete locally, it seems the National Maternity Ambition is including IVH grades 1 and 2 as brain injury. Is this correct? Was this the intention? I worry that this will dilute out the more important higher grade IVH scan results.
Lawrence and I have been corresponding about this morning, and I think Lawrence and I agree that the tool that he's talking about for the implementation guy could do with further iteration, which is a good news because Sarah, Tony and I have been iterating it further. It's not yet perfect. I think the NNAP answer to the question, though, Lawrence, is that describing the brain outcome at not just IVH3-4 level, but describing any IVH that occurs is a good thing to do, if only so that we can be really confident that we distinguish grade 2 from grade 3 IVHs. And again, I would draw people's attention to the definitions of those that Chris and other true experts, of which I'm definitely not really one, defined, and there you can see those in Badger. Chris, you wanted to come in, I think.
Yeah, no, I was going to just say that for the National Maternity Ambition, for the national data for brain injuries occurring shortly after birth, that is only grade 3 and 4 IVH. That isn't grade 1 and 2. Although the measure monitoring the toolkits and things obviously has different processes, so that may be using different things. But yeah, the National Maternity Ambition brain injuries definition is only grade 3 and 4, and cystic proventricular accumulation, as well as the other conditions that I mentioned.
Great, thank you both. So a question from Claire Kane, and I think this is one, if people in the chat have answers, please do respond to Claire. Do you have any advice or standard guidance on getting time resources for clinicians, data managers to support the data checking process to achieve really good quality local data completion? So I'm sure there are people out there who've managed to do this in different ways, so please do respond to Claire, but I don't know if you've got any thoughts on that, Sam.
I think the real answer to that question is no. I think data management provision in trusts and at regional level is very variable, and I actually don't think it takes an enormous amount of time, but it does require some focus. And there's bigger the hospital, clearly the more actual time it takes. But getting your head around the process. So thank you very much for engaging in the webinar. I'm really happy to pick that up outside, and indeed any of these questions outside. There's only one Sam Oddie. I'm quite easy to find, but you can write to NNAP.
I have to go, I'm afraid. I've got another meeting now. I haven't realised it's 2, but very nice to see everybody.
Thank you so much, Chris. Bye. Thank you. Yeah, we have run out of time, unfortunately. We have got a few more questions, which is fantastic. We've had loads of questions come through. We'll try and follow up on them, but if you do have questions, probably the best way is to email your questions to nnap@rcpch.ac.uk. I've replied to a few people asking them to do that, but if you haven't had a response to your question, please do that, and as a team we can get back to you.
Rachel, I'm going to pick up just a couple of these. Paul Corley. Yes, I think if you address your data cleaning on the spreadsheet that we make available to you by the SharePoint, that will address that. Rosalind Gar, if the ultrasound is normal, definitely you should record that it's normal. Record that in Badger. You don't have to record every single normal ultrasound, as long as you record one that answers each of the questions early and late. Again, see the measures guide. And donor breast milk. The question is about the audit questions are about maternal breast milk, not about donor milk. Thank you all so much for your engagement. Thank you, Rachel and Lucy, for organising this, and Chris, truly expert special speaker. Thank you very much indeed. Please do write to us. Here's the address on the screen. A Zoom wave from me.
I've got a couple of last points I can make, Sam, before we go, if that's all right. So the webinar will be available on the website shortly, and we'll email you when it is. Same with the 2024 measures guide, that's coming soon. We're launching a feedback survey this afternoon. Please do take time to respond to it. It's not very long. Give us your thoughts about how we're doing and what you want us to do differently or extra. And also we'll be sending around a feedback survey for this webinar, so please do take time to respond to that. Email address is on the screen if you haven't had your question answered, or if you've got more questions. Thank you so much, everybody, for attending. Have a good rest of the day.
Zoom wave. Cheerio.